Welcome to 50 Shades of Pink. I'm Kathy Weaver, and I'm Executive Director of Guideposts of Strength. We at GPS want to help you through your cancer journey. And we do this by providing trusted experts like our doctors here to help you with the professional end of information, but also to help each other with this whole room full of survivors, because nobody knows your journey better than the survivors. So our organization combines the strengths of the experts and the people who've been on this journey to help the next person on the journey take each step. And that's what we're about. If you'll please fill out your forms. If you're not registered with us, then this is how we'll be in touch with you by either mail, email, or phone to let you know about our organization and the events that are coming up. We're also interested in helping you if you want a mentor or if you're a survivor and want to be a mentor or volunteer with us. Today we have medical oncologist Dr. Susan Williford from Emorywood Hematology and Oncology. I know a lot of you know Dr. Williford, and she has wonderful shoes on, as both of our speakers so far do. Gynecologist and obstetrician Dr. Elisabeth Stambaugh from Pine West OBGYN. And Dr. Sidhu is on her way. She's running late, but that's what happens when you're a doctor. Things get in the way. And those things usually involve one of us who needs to be treated. So we all sit here and understanding because we've probably been the patient she needed to stay late for at least one time in our life. She is with the Hayworth Cancer Center, and I think I said she's a radiation oncologist. As the name 50 Shades of Pink not so subtly implies, we are here today to talk about how your cancer diagnosis and treatment affects your sexuality, your sensuality, your self-esteem. These are topics that not everybody covers, but we're not your mother's cancer organization. We want to deal with a lot of the topics that have been sort of discussed to the side, and that's why we're here today. A couple of notes to keep in mind. If you have a question and you're a little bashful about asking it, you can write it down and give it to Ellen in the back, or Michelle back there. I was going to say she's in pink, but aren't we all? And we'll be glad. They'll just bring it up to me and we'll discuss it. But we'll have plenty of time for you to ask questions, and so just feel free to say what you want to say. Second, since we're most likely going to discuss some sensitive issues today, I ask that each of you respect each other's privacy. It's fine to go home and talk with your friends, your sister, your mother, your spouse about the topics we discuss. But don't go to the Harris Teeter tomorrow and say, look, the lady on aisle 4 has a lower sexual desires than she used to. We don't want you to do that. Just respect what we talk about. We are going to be doing some photos. We are going to be doing some filming because we want people to know that what we're about. If you don't want to be in a photo, let us know. The filming is going to be just filming the speakers. Your voices may be heard as you ask questions, but your faces won't be shown. So again, just to respect your privacy. That sounds like it's going to be a scary program. It's not. We just know that these are not the questions that everybody is always most comfortable asking. And we want to make sure you feel comfortable in this setting because it is a comfortable, safe setting. We just want to learn from each other. But if things are said in confidence, please keep them in confidence. I'm going to turn the program over right now to Dr. Williford. When our food comes in, we'll work that out as it happens, but just be patient with us as the food's coming in and as Dr. Sidhu comes in. We have a side door here. Ellen, should we close this one? I'm just thinking about outside noise. Are we okay with that?
I'll go around and close.
Okay.
Also, the bathrooms are right through that door.
Thank you. The bathrooms are right through this door. Dr. Williford?
This is so cool. When Kathy talked and Ellen and Michelle talked about having this session, I thought it was a great idea. But just last week in this email, they had a big Chicago Tribune article, and it says, treatment ends and life is poised to return to normal after I'm treated for breast cancer. Survivors enter an often bewildering new phase of cancer care. Some patients may face a host of physical and mental challenges ranging from fear of recurrence to concerns about leaving their oncologist, questions about fertility, depression, and sexual difficulties. That's exactly what we're here for today. It's just to talk about things in a casual forum. So I'm going to let Elisabeth talk about the gynecologic part of it, and then I'll come in with the breast cancer part, and Dr. Sidhu will talk about the radiation part, I'll do the chemotherapy, hormone treatment. And then we have a list of questions that people have sent in. So if you guys don't have any questions, we've got questions that may be the same questions you want to ask. So you don't feel like you have to ask a question. We have a list of questions that people have asked us to talk about. So we'll just start like that. Okay?
I have to tell a personal story, which is when Kathy sent me an email asking me if I would do this and told me what the title was going to be. I was at the beach with my family, and so I was laughing about my husband knew about the books, and I was telling him about it. My mom said, well, what's that? So then I was telling her, so then she decides she's going to read the books. And I'm like, okay, my mom. I almost had to do a little disclaimer. You have to know. Anyway. But I love it. And I think this is a terrific topic. Honestly, most of the stuff we're going to talk to today, I could talk to any of my patients about, because this issue is completely pervasive. It's just such a personal issue, and often women don't necessarily want to talk about it. They're embarrassed to talk about it. There are some very specific things that we'll talk about with cancer survivors, but honestly, most of these issues, you don't have to be a cancer survivor to have a lot of these problems. So it really goes across all different walks of life. I will tell you that actually the most common age range of women that I see who come in complaining about decreased sex drive is women with small children. Because, you know, sex drive, it's so, when you first start a relationship with someone, it's just the two of you. There's passion, there's excitement, there's romance, and it's all focused on each other. Well, as soon as anything draws that focus away, it can be very hard to pull that focus back. And one of the biggest things that draws that focus away is having a small child, as you know, to chase around all the time. And as a mom, your level of attention, even once they start to be a little independent, you always know where they are. You're listening, the sounds are different. And so you're on until they go to bed, and then you're exhausted. And if you even try to get a little bit of me time, you're actually lucky if you manage to find that. But it's certainly very hard to then have enough energy left and mental focus to be able to focus on your partner. So it's a very common, I'm mostly saying that it's a very common thing at all ages, not just menopause, but even younger women, and that's a big deal. I also wanted to talk about the thing that a lot of people say that it's just in your head. Well, I'm here to tell you that it is mostly in your head, but it's more complex than that. I mean, for men, 95% of their sex drive is you know where. All they do, they just want it. It's a physical thing. But for women, 95% of ours is not physical. Now, it's probably a little higher percentage when you're dealing with menopause and cancer survivor, but still, a lot of it is up here. There's a lot of issues that we're dealing with when we're thinking about sex drive. But there's issues that if we recognize them, we can help address. Different things go on, how tired you are, what else you have to do on your to-do list the next day, body image, whether you're a cancer survivor or not, body image is huge with women. I mean, the secret is that most men don't care. They just want it. But it's true. But for women, I mean, it still isn't so much about, oh, you're not going to want me, but it's about how sexy you feel. And if you're not feeling sexy about your body, then it's very hard to get in the mood. So that's a big deal, and certainly an even bigger deal if you're dealing with something like a mastectomy and the way that makes you feel about your body. There's also a lot of differences between men and women in the way we become aroused. For women, normal women, it takes us about 3 times as long to get aroused. So foreplay is a huge deal. Whether your partner participates in that foreplay or not, foreplay is a huge deal. And so a lot of it, again, one of the advantages of having most of our sex drive be up here is that even mental foreplay is important. And of course, some of this, including the focus, including the foreplay, is why candlelight and romantic music work. Because it helps draw away your focus, but also it kind of gets you in the mood because all you're thinking about is that partner. Although everybody comes in and says, oh, but come on, when we first started a relationship, it was so natural and easy, and I just wanted it all the time. But all those other focuses come in. It would be great if it were that spontaneous. But I tell my patients all the time, you know, the question is whether for you and your partner, you decide it's important, and you decide it's something that you want to work on. Maybe you sit down and talk. I have a lot of patients who sit down and they say, you know, we've decided it's just not an important part of our lives anymore. And that's okay, as long as especially as long as it's a mutual decision. It is very hard to sit down and actually talk to your partner, but that can get you very far towards figuring out how to feel sexier and really even just to get in the mood. So that's very important. But I think, you know, beyond that initial relationship passion and romance, think it's got to be a conscious decision that I'm going to work on this. And although that doesn't seem so romantic, it will really help both you feel sexier and your partner. I think I'm going to stop there because some of the other stuff will come up in questions.
Okay.
You want to eat?
I think they're still setting it up, so we'll do this for a little bit and then we'll.
I have just a couple things that I've been in practice for 25 years. I'm the old lady in the cancer center. But there's some things that people have said to me over the 25 years that I really haven't read in a textbook and stuff. And I'd like or what they've asked me about repeatedly. And one of them is I never thought I would get breast cancer or any cancer because there's no family history of it. And I think everybody in this room needs to know that most cancers are not familial. They're not family related. And that's important for all of us to know that it's not something we've done or, genetically we've gotten. Most cancers are not familial. And then what I've never understood is why all my sensations during chemotherapy become dull, but I can smell like a dog. I can smell anything. And I don't really understand that, and I've never seen that written in a textbook. And so we ask people not to bring smelly foods into the chemo room and stuff. But I've had people say, I don't smell right. I can't. My skin smells weird or something. But for some reason, I know it's a compensatory mechanism, but I've never seen that written about. But I've had people tell me that over the many years I've been in
worried that I smelled bad.
Right.
I asked my husband, I said, tell me, do I smell bad?
Right.
Of course, that's not going to make you feel very sexy if you think you smell.
No, exactly. But did any of you feel that way? The smell?
Yeah. And then another thing that they say, we've read all about the different phases of cancer, like the emotional phases. We're mad, and we're dumbfounded by it. We're mad, but all those emotions don't always come in succession. And we know that, and most people in this room know that. But one of the things that I really wasn't ready for, I think, is that when we're done with treatment, we're supposed to be normal. Well, we're not. And we feel abandoned by the oncologist. We feel abandoned by our friends. And I don't really know why, except that during all of our therapies, it's just like when we have surgery, we get somebody was talking about last night at the dinner, I got so many flowers, I thought it was my funeral. I got so many flowers and so much food, it was just overwhelming. And then I'm all done with my treatment. Then there's really nobody. Like, nobody pays me as much attention. My oncologist isn't seeing me anymore because they don't have to, which we'd like to see you, but we miss you too. So I think when you're done with everything, you need to know that it's not like I'm suddenly normal, because at that time, a lot of times when we're done with our treatments is when we allow ourselves to really grieve, to really think what we've been through, to allow us to deal with the scare of the cancer, our missing body part, our relationships, things like that. We've actually had time to reflect. So that feeling is actually common. Families do not understand that feeling because they've grieved so much to begin with. They're just ready for everything to be normal. So you need to know your families, the grieving process or shock of the cancer is different from families to patients. So families typically have all these issues to begin with, and then they're done. So when the patient's done and allowed with their treatment and allowed to really reflect, the family's been long ready to move on with things. So I just ask you to be patient with your family, be open and communicate with your kids, your spouse, your mom, your dad, whoever it is, because they can't read your mind and they're kind of already done. And I don't want you to feel like your doctors are abandoning you or your nurses or CMAs. It's not that we're abandoning you, it's just that you don't need to come as much, which is great, but it's still, you feel that loss of the attention and you feel some fear then. And I think that what I tell people, it's a new normal. We have to get where our new normal is. It can be positive or negative. You can say, well, gosh, look what all I've been through. I've survived it. I'm here. And you got to learn to live with how your new body is, how your new mental outlook is. And it can be positive if you look on it that way. Things that used to bother you may not bother you as much anymore. So it can always be positive, even though this has happened. Somebody said this to me last night, how do I ever feel cured? And I want you to know that we do get cured of cancer, but even if we don't get cured of cancer, we can live with cancer. And the thing that cancer or any catastrophic life event does to us, life is never certain. I could walk out of here, fall on my face, and die in a second. Cancer makes us realize that more. So it's not that cancer has ever, it doesn't take it away from the fact that we don't have the promise of the next minute. It just makes us think about it. And then I will say, going along with that other point, is that sometimes patients feel that family and friends aren't helpful, or too helpful, or too mothering, or not enough. And the problem is they can't read our minds. So what I say is open communication, especially in a relationship. You have to say, like I would say, Tim, I'm just crabby today. If I yell at you, I'm just crabby. And so it helps that partner or that friend or mom, dad, whatever, know that it's not something they've done, because they're always afraid that they've done something wrong. So it's good to say, I'm having a bad day, or I'm having a good day, or whatever, and just keep open communication with them.
Another part of the open communication is with your partner in regards to sex. Men do not understand that it's so much more complicated for us. They don't get that, because to them it's this simple world in terms of sex. And so you're probably going to have to tell them over. They're going to think it's them. Oh, it must be me. What's wrong with me? You probably will have to repeat it over and over again. It's not you. I'm too tired to, this is not about you. And keep that communication going. And you got to keep reminding them, because they'll forget.
It's interesting. We did this survey. It was some type of company survey where people filled out these questionnaires in the waiting room. It gave people something to do, and we did it for this company. 100% of people put they had sexual problems. Now, these are all our patients, but there's men and women. And those were only the people that actually wanted to fill out the survey. There was 100% sexual issues. Now, not everybody wanted to talk about them, but this was a survey, so you were just check, check, check. We were impressed at the number of people that are in the same situation with that. They just don't talk about it.
One of the things that I want us to kind of open up the forum on is a couple of areas, and both of you have touched on this, the fatigue. I mean, we have a lot going on in our lives, but you put cancer in, you put surgeries, anesthesia, chemotherapy, radiation, and you're a lot tireder than you ever thought you would be. And I guess from the standpoint of somebody who's been through this, the fatigue lasted a lot longer than I expected, and you're right. I mean, when the end of the day comes, there's not a lot of energy left for playing. And is that something that has, does it last a long time, the fatigue from chemo and surgery? What's kind of a normal time frame to look at?
It varies according to the person, but they've done studies on this, just like chemo brain. They actually, talking about the fatigue, though, in particular, we do know that exercise, some type of structured exercise program, is awesome for cancer-related fatigue. And it means and you have to put it as a priority, like a job. Okay, it is 3 o'clock in the afternoon. This is when I do my exercise for 30 minutes. It doesn't have to be like a rigorous, I go to the gym exercise program. Some type of light exercise for about 30 minutes, just several times a week, is enough. But it does help cancer fatigue. Same way with chemo brain. They actually studied chemo brain because patients complain, I just don't think right. So they did a study and found out that a large amount of patients, even before they have chemotherapy, have this brain like we can't think quite clearly. So we don't know if some of it is chemically related. We think there is a chemo component to it. We don't think it's permanent, but it can take a year or more to where you're just like thinking right. Some of it is because we're so overwhelmed. So we just aren't focused, and or we have to get from appointment to appointment. We're not things like that. But it is real. There's no question. The fatigue and the what we call chemo brain are real entities.
And even after surgery, I mean, we do a lot of minimally invasive surgery. So 4 weeks afterwards, when we see patients back for their postoperative checks, physically in terms of pain and those kinds of things, they're feeling pretty good. But they say, "But I'm still so tired." And it's not about losing blood, and they're just. That the stress of going through surgery, even if it's minimally invasive surgery, those stress hormones and everything that affect your body, it can take several months to get back, just from a fairly minor surgery, to get back to 100% in terms of fatigue. So it's a real thing.
I'm going to launch into a topic that is one of the biggest ones that I hear mentioned from people. And we've done focus groups, we talk with patients, really trying to get a feel for what people want to talk about. And this one, I think it's okay. Mike's in the room. We'll let him hear this. Vaginal dryness. It's huge. If you've been through chemotherapy, mine was for breast cancer, but is dryness typical with all chemotherapies for any type of cancers?
I think vaginal dryness in women, especially who have taken chemotherapy, is because you have immediate menopause. Mm-hmm. Like whether you're premenopausal when you start the treatment, you will go through temporary menopause, and so it's unlike the women that go through natural menopause to where the estrogens and everything slowly fall. You do it immediately.
Is that true of any chemo or just mostly breast cancer chemo? Do you think it's true with pretty much any chemo that puts you into menopause?
Any chemo that puts you into menopause, not all chemos will, but hormonal treatments often don't. But any chemo that puts you into menopause, it's a sudden, within 30 days. Usually, premenopausal women, when they start chemotherapy, by the time they get their second treatment, they don't have periods anymore. So I think the vaginal dryness, a lot of it is hormonally related, not just the drugs, and not just the chemo drugs, but I think it's a lot hormonally related, but it's because you have sudden onset of those things. But it is a big problem.
And what happens with dryness, we talk about dryness, and so people say, well, why don't lubricants work? Well, sometimes they work for some people, and that's enough. But when you lose estrogen, the tissues in the vagina and the external areas as well become thin. We call it atrophic vaginitis. It atrophies, and the tissue actually gets very thin and fragile, in addition to producing less lubrication. And that's why for a lot of people, lubricants don't work. You can use vaginal estrogen, and at very low doses that we use to treat atrophic vaginitis, it doesn't change your blood hormone levels at all, so you can use it even as a breast cancer survivor, as long as it's okay with your oncologist.
So that's one of the things that you would recommend. But for those of us, what's the first thing that you would recommend? To try just a lubricant to see if that helps?
The lubricants have absolutely no side effects other than, and some of them are very low volume, so it doesn't have to be so goopy, that are just over the counter. And certainly if that helps, there's no side effects. But the vaginal estrogen is we use it at such low doses that it's really, other than helping those tissues, it's not going to have much in the way of side effects.
And they've actually done studies with vaginal estrogen and drawn women's blood estrogen levels. And a very low dose that the gynecologists use are not dangerous for breast cancer survivors. Always when we have an estrogen positive breast cancer, it's scary for us to talk about putting estrogens back in our body. But it's okay in the low dose that's used. We would try other options first, like the lubricants, but then if we have to, we'll use the vaginal estrogens. And it's interesting, and Elisabeth knows much more about this than I do, but oral estrogens are not as good for vaginal dryness, atrophy, as vaginal estrogens, which I think is cool.
Well, and the estrogen receptors that are all over your body are variable in how much estrogen they need to work well. And actually, it's very individual too. I have some patients who take a very low dose of oral estrogen who they're fine. They don't have any problems with vaginal dryness. And other people are on kind of a regular dose and yet still have a lot of vaginal dryness and have to add in the vaginal estrogen. So it can be different for different women. Did you want to introduce Dr.?
Yes, I do. Dr. Colby Sidhu is here. She's a she's a radiation oncologist, I'll get it out right, at Hayworth Cancer Center. If you've had radiation therapy, you probably know where that is. That's downstairs. We have been talking so far about, each of the doctors here talked a little bit about how their aspect of medicine is affects a woman's sexuality, sensuality, and self-image. And so I'd like for you to talk a little bit about how radiation oncology can affect the way you feel through your cancer journey. And then I've got some questions that have been submitted, and we'll talk about, we'll get some questions in a few minutes about how radiation therapy can affect those sensations. One question I want to ask, Ellen, are you back there? Ellen? What are we ready for lunch? Let me let Dr. Sidhu speak, and then we'll work on lunch. If everybody's okay with that. We're good? All righty, Dr. Sidhu.
Great. Well, thank you for inviting us here. With radiation oncology, we find that it is a field that not too many women are familiar with before they're actually ever diagnosed, and so there definitely is an educational aspect to it, and we often not uncommonly are asked, well, am I going to be radioactive? Is it okay to be intimate? And if the women don't ask, the men often do if they're together. So those are the type of sort of broad subjects that we come across when we're introducing the concept of radiotherapy. And then, once we have a better understanding of what's actually happening and how the treatment works, then there definitely are side effects to the treatment as women are going through the active treatment and then afterwards as well, that we try to make them aware of. So just being aware of what's is going to be happening and how to prevent some of those symptoms can give at least some empowerment to women that are going through the treatment, and that often does help as well. But there's certainly with radiotherapy, as with some of the other medications and treatment options, often how it affects a woman can be quite individual as well. So we give patients a broad introduction, knowing full well that there will be some specific issues that are may come up as treatment's going on.
I've had bilateral mastectomies, so we know that sensitivity is gone in this area. Can radiation therapy affect the sensitivity of your breast?
Yes, it can, but not necessarily. Okay. And it really, I think in the past, before we put a lot of emphasis on cosmetic outcome and long-term tissue toxicities, it was more of an issue. I think at this point, we have made some changes in the way the radiotherapy is actually applied, the dosing, the type of beans we use, and so forth. So it tends to be less of an issue, but it certainly is still a concern.
What I'm going to ask you to do, and you can, let's say this side of the room first, go back, get your food and your drinks and bring them to your table, and then when that side gets through, just so we don't create a bottleneck, we'll let this side do it. And once you bring your food back to the tables, then we'll pick back up with the discussion, if that's okay with everybody. Does that work out? And if y'all want to eat now, you can, or if you want to wait till afterwards. I generally like to wait.
I just eat all the time.
Yeah.
That's
The
fun.
food went to the wrong place.
No.
Yeah, get the food. Hey, how are you? I've seen you in 1,000 years.
1,000 years.
How are you?
But I will be seeing you because I'm going to come up and volunteer. Yes, Jimmy. Jimmy was killed in a car accident 4 years ago. 42. Yeah, he was hit by a drunk driver, and he and another passenger died, and a third person was injured. Anyway, the corpse found there.
Where is it?
Getting the team together.
Anyway, there are a lot of things they didn't do, and blah, blah. You'll see it on Sunday.
Are you leaving here, or are you?
The last thing that happened was the case had finally, after 4 years, it continued. There's supposed to be a hearing to decide whether there's going to be a plea bargain or a trial. The girl was not an American citizen. We only just found that out.
And Philadelphia.
Got on a plane and went to Brazil. They had never taken her. Among other things, they didn't.
4 years, they've never taken her passport.
Yeah, they're very strange. Very strange.
I'm sorry. You look beautiful. I hadn't seen you in, gosh, it's been, how long has he been gone?
13 years.
I was going to say, it's at least 10.
13 years.
It doesn't seem like that long, but then, yeah. It
You're
doesn't-
great. I just listen. I love to listen.
Oh, you're so sweet. Well, it's good to see you.
Yes.
Yes, we love her. Yeah,
Hi. She's awesome.
and we're glad she's got more of a presence again.
Like night sweats.
But we've always,
Noticeable
even when she
depression. Do you actually do the back surgery?
All the time.
she's just great to work with, especially for
Why?
cancer.
Why?
Patients here, they want to have surgery.
It's risky.
But we have to. That's all we got.
If that's all we got, then you have to.
The reason we do is because the antidepressants help hot flashes.
I know,
And
especially that SNRIs.
yes, and what they do is they don't make them go away. They just make them not so intense. I mean, some of these women sweat so bad they have to take 2 and 3 showers a day. They can't. I mean, they can't live like that. And the clonidine doesn't work as well. The Neurontin, you have to get up to such high a dose usually for hot flashes. You're like. Ugh. So the Effexor helps with the severity of hot flashes. So we have to. It's FDA. Actually, the cool thing with Effexor is 25 BID, which is what was used in the clinical trials. But it's hard to find Effexor. It's all Effexor XR. You know, I mean, they don't make it that much.
Not generic yet.
It is generic,
Oh, and it's
but they usually just have the long-acting one. So usually for just hot flashes, not depression, I give them 37.5, the long-acting.
But it's great.
And then I tell them that they can take 1 or 2 a day. But
They're only taking one directly morning and night.
I usually get it shouldn't matter, but if my hot flash, the problem with menopause symptoms is you get insomnia, hot flashes, all the dryness and everything they talk about, mood swings, all that junk. So I usually give it at night because it helps with my hot flashes at night. So you give it like before you go to bed because it'll be most intense when it's just fresh in your body, even though they quote last all day, they don't last as long as so we do all this.
I know some metabolism and like the person that I've talked to.
There's a bunch of folks.
She took it last night and now she's feeling like fuzzy. Probably because everybody's just acclimating to it.
Right.
She didn't feel much different at night. I almost wondered if she took it like BID, like you said.
But you have to get to take it BID. You need the short acting stuff. So, and it's hard to find. I stopped giving
Estrogen or black cohosh.
they've done clinical studies with Estroven is a soy-based preparation. So is black cohosh. They're soy-based. The gynecologist will still tell you to take them, but in a study of a strict amount of that drug with breast cancer survivors, it did not do any better than placebo. So we actually have data in breast cancer survivors with soy-based preparations. We used to worry because soy is a weak phytoestrogen. We worried about its estrogenic effects, but we stopped worrying about that years ago because it's such a weak estrogen. It's a weak phyto. It really has no estrogenic. It's not a cancer promoter. So all I tell people is that I don't have data that it'll help you. It won't hurt you. You know, some of it's placebo. You take something, you think it's helping you. Just like melatonin, was prescribed for
She's the hospital
jet lag. And some people say it makes them sleep, and so people take it, and I don't care, it won't hurt you. But we do have data in breast cancer survivors that the one that's soy, black cohosh is what they use, doesn't help. But it won't hurt them. But you have the same way with there's flaxseed oil is one of the lay things that may help you. It won't hurt you, but there's no data in cancer survivors that it helps you. But I always say, if you want to take it, it's not going to hurt you. Because people say, well, my neighbor took flaxseed oil, and that's what helped my hot flashes. And I said, fine, take it. It won't hurt you.
Yeah. And it's helping me know that.
Do you know there's a $3 million thing called the Soy Connection? It's out of Kernersville. They sell all this crap. It tastes like hay. We got some one time because they're like soy bars, soy pills, soy whatever. They have a $3 million business. I don't know if it's still that way, but soy was real popular about 5 or 10 years ago, but it's kind of fallen off in popularity. But health food stores will tell you that, but it won't hurt you.
Okay.
You can eat all the soy soy bars. But because we don't want to use estrogen. We really are limited, and there's so much data with all and the reason we use a lot of Effexor is because there was about a couple of years ago, tamoxifan's a prodrug. It has to be metabolized by the CYP2D6 enzyme to the active component, and these antidepressants inhibit that enzyme, okay? So they can like interfere with the metabolism of tamoxifen. So we thought, well, maybe people aren't really getting the drug because they're not, So they did studies on that. We think that's probably not true. But Effexor does not.
With SSRIs, they can.
Yes. So if we have a choice, because some of us still feel a little uncomfortable about that, we will prescribe something that doesn't. Effexor doesn't. Zoloft Weekly does. Prozac definitely does. Paxil does. Wellbutrin does not. No, Wellbutrin Weekly does. But we know Effexor does. Years ago, we were worried that tamoxifen is a prodrug, and the drugs that inhibit the CYP2D6 enzyme to metabolism, we worried that they were interfering with tamoxifen metabolism, and that may be an issue. But now, as of last breast cancer meeting in San Antonio, I think last year, we aren't worried about it. They did a study. So it's not, even if you're not converting it to active tamoxifen to its active metabolite, you do apparently get some benefit from it. But because of that, we know Effexor doesn't, so that's our favorite one to do. But I think Wellbutrin does a little bit, but not bad.
Wellbutrin's better for sex drive.
It is.
True.
And Wellbutrin doesn't.
Good, it sounds like 90 from, or are those just...
You need water.
Yeah, because I don't know. I'm fine. But it does. The Wellbutrin's good because it doesn't mess with sex drive and it doesn't make you sedated.
Right.
So that's why.
If someone has like
But Effexor. But they've studied lots of the antidepressants with hot flashes, and all of them seem to do something.
The only great negative texture is when people stop taking dopamine.
Okay.
Even at like half pace of what would be normal, because you get those horrible brain zaps, it feels like lightning in your head. It's almost frightening. So you're just like, oh, I don't like this anymore. Then it's concerned.
Yeah, but we give it a lot because that's all we got.
Yeah.
We really don't have, the other ones just don't do as well.
Yeah. Well, thank you. I appreciate
But I like Effexor because it's, I know it doesn't interfere with, now the aromatase inhibitors are not prodrugs, so it doesn't matter. So you can give whatever antidepressant you want with them. But antidepressants do help hot flashes regardless of whether it's natural menopause or it's drug-induced or whatever.
Okay. Very good.
But she was just saying she doesn't like that we give antidepressants and people aren't depressed as hot flash treatment, but we don't have a lot of other options.
Yeah.
So we have to. Yeah, but usually for hot flashes in the studies anyway, they had to get up to a ton of Neurontin.
300 milligrams.
Yeah.
3 times a day.
Yeah,
Although I've
that's a lot.
had a bunch of folks who've done well just doing it at night.
Yeah,
Because it makes
right,
them so
right.
sleepy.
They
But
sleep
if
through the hot flash.
The night sweats are a big deal. If they just take it once a day at night,
Yeah.
then sleeping is good. And it really helps the hot flashes.
Yeah, no,
One
I
of the
trust
questions
you.
also
I don't
was
like
about-
it. I just need to know. Like,
One of the questions
That's why we use so
about
much,
the natural
because it works
I
better.
just asked them and they said they're all good.
okay. I'm gonna let you get that.
I'm good.
Okay. Okay.
Thanks, Mike.
We'll delete afterwards.
He's so cute. He's so cute to serve. He does GPS, and one time I was coming in, I thought I'm going to open the door for him.
What I'm going to do is
He got through into the office before I could walk to the front of the building.
I'm going to bring up a couple of things about feeling pretty, the things that we have back here people can look at, and then start opening them up to questions.
Okay.
But I want to talk about hormones a little bit.
No, but we all ask them.
Kathy, I want to talk about hormones a little bit after you.
Okay. Everybody, can I have your attention again? While you're eating, I want to mention a couple of things. Dr. Stambaugh has something she wants to mention, and then we're going to open it up to questions. I'm the plant here. I get to bring up some of the issues that may be a little difficult for everybody to talk about. Scars. For those of you who've had mastectomies, even other cancer-related scars, we don't really like to see them when we're intimate, okay? Because it's a visual reminder of what's not there. And I've had reconstruction. I still have a lot of scars. One of the things I want you to look at, Tricia from Tricia's Pink Boutique and Justine from Second to Nature have both brought incredible displays on each of their tables of undergarments that make you feel pretty. And as everybody here has told you today, so much of this is in your head. It's how you feel. Yes, it's a splurge to go buy a pretty lacy lingerie set, but if that's what makes you feel good, it's not really a splurge. I mean, you'd do that if you wanted a pair of shoes that felt good. And I want you to go back and take a look at these things because they're made for people like me who are very scarred. And I'm not comfortable, you know, without looking good. I want to look good. I mean, it's a vanity thing, but it's also a mental thing. There are also some, there are prosthetics back here. There are prosthetic nipples. There's the prosthetic that's really incredible back there that actually is contoured to fit the scars on your chest, so it fills in the indentations. It even has some veins on it. I guarantee you it would make you feel pretty and more whole than you do if you've lost body parts. And some people's reconstruction is excellent, some is not. But I want you to be able to talk to us about things if you feel like it. The options nipple reconstruction, some of you may have had that. Some of you may have tried nipple tattoos. All of these are trying to make us feel more like we were before cancer. And this program is not just about breast cancer, but those are that's obviously one of the most sensitive areas of our body, and when it's been operated on or removed, you do feel different about yourself. Dr. Stambaugh has some things she wants to talk about, but I wanted to make sure I drew your attention to these areas to look at on your way out, because you're going to see options that you may not have realized were there. Okay.
I was going to talk a little bit about hormones. A couple of the questions came up talking about hormones, and certainly for breast cancer patients, usually hormones are contraindicated. One of the questions that was submitted beforehand talked about some of the different things in the community that are talking about working on increasing your sex drive, like these implantable, like the Amor-V. I will tell you it's hormones. And just because something says that it's bioidentical or natural, there's absolutely no evidence that it's any safer for you than the stuff that we prescribe. That also includes anything that has black cohosh in it. Any of the herbal supplements over the counter that usually work very well for hot flashes, it's because they have black cohosh in it. The reason black cohosh works is because it works like an estrogen. So you need to avoid those too. The couple things that do help with hot flashes, we were talking about, there's a lot of the antidepressants. Most of the antidepressants do work very well with hot flashes. And actually one of them, Wellbutrin, works very well also for sex drive. We know that most of the antidepressants that are out there, Prozac, Zoloft, Paxil, all those, we know that one of the side effects is that it can decrease your sex drive in anyone, men or women. And then they noticed that women who took Wellbutrin didn't have that problem, so then they took it as a study and gave it to a bunch of women who didn't need it for any reason, for any moods or anything, just to study it, and they did have a good percentage of them that it did increase their sex drive. If you've ever had a seizure, you cannot take Wellbutrin at all. Dr. Kangan, who's the psychologist, was bringing up that if you have significant anxiety issues, then Wellbutrin may not be the best thing for you. But that's certainly an option for a lot of women as well, is Wellbutrin.
I want to let you ask questions. If you don't have some, we'll go back to our questions that have been sent in, but we want to really open it up.
Okay, and I asked Dr. Stambaugh this before at the break. So you're premenopausal, you go through instant menopause. Are you now postmenopausal?
You'll know
When do you do tamoxifen? When do you do an AI?
Okay, that's a great question. When you go through menopause that's chemotherapy induced, it depends on how close your body is to natural menopause, but we say that you have to be without menses for a year to say you're truly menopausal. So anybody that's perimenopausal, like my periods, I still have them, but they're getting a little irregular, or I had a couple this year but not sure, or I went through instant menopause, we treat you with tamoxifen until we are sure you're menopausal, because the AI drug class, the aromatase inhibitors, don't work if I'm premenopausal.
And if you don't have symptoms from, say, the tamoxifen, hot flashes, and menopausal symptoms, does that mean your tamoxifen is not working?
No, it doesn't. They've actually studied that in depth. We thought a few years ago, because tamoxifen is a prodrug, it's converted in the liver by a fancy enzyme that I actually know the name of, which I'm surprised I do, but it's converted to an active metabolite, and the antidepressants, some of them interfere with this, as other drugs can interfere with the active conversion of tamoxifen to its endoxifen, which is its active metabolite. And we used to say, well, maybe hot flashes was good because it meant the drug was working, but that's not thought to be the case anymore.
And not all women who go through menopause have hot flashes, which we have no idea why that is. But some women have a horrible time with menopause and will never stop having hot flashes. Other women barely notice it. And then the majority of women with natural menopause have bad symptoms for a couple of years and then it eases off. But we don't really know why that's different. So that makes sense that no hot flashes doesn't necessarily mean it's not working.
Yes, ma'am.
Okay, I have terribly now hot flashes. So what can I take? I'm a BRCA1. I have the BRCA1 gene. So what can I take for my hot flashes that would not cause me a problem? Because I see Dr. Hubbard. So my cancer wasn't hormonal. It was invasive. So he was,
He probably still doesn't want you to take hormones. But you can, the antidepressants can really work very well in a lot of cases. And then there's one other drug that only recently in the last year or two we've started using for hot flashes, and that's Neurontin, which is gabapentin. It started off life as an anti-seizure drug, and then now mostly it's used for things like peripheral neuropathy or nerve pain associated with shingles. So anybody who's had shingles might have been on Neurontin. It's good for nerve pain. But we've now studied it, and unfortunately, in order to have it work against hot flashes, it has to be fairly high doses, and the number one side effect is significant fatigue and sleepiness. So in order to get rid of daytime and nighttime hot flashes, the doses they studied, it was like 300 milligrams 3 times a day. So it's a lot. And most people take like 100 milligrams. So 300 milligrams 3 times a day. But for women, especially who their sleep is interrupted by a lot of night sweats, I have a lot of women who take it just at bedtime, take 300 milligrams, and it really helps through the night, which actually makes them feel better during the day. So those are some options.
They gave me gabapentin.
At what doses?
And she just changed it to a higher dosage. And then they gave me also Stambaugh.
Because the gabapentin, in order for it to really work for hot flashes, the dose is 300 milligrams.
Really?
So you might want to check the dose, because that's higher than most doctors are comfortable with using.
Yeah, because I don't think it's 300. I think now I think I'm only at 100.
And it helps to ease up to it too, but that might help.
So
One other thing, how do you feel about progesterone cream for breast cancer patients?
I think the creams and not the pills, I'm a little more comfortable with creams, but I still don't like hormone. I just feel weird about giving people hormones, especially in people that have hormone. Even testosterone, we're a little nervous about, although we used to use a drug called halotestin that is a testosterone drug for treating metastatic breast cancer. The interesting thing about breast cancer is you can give breast cancer really high dose estrogens and suppress it. But you can give them low-dose estrogens and stimulate it. And even there is some data that women that take estrogens only without the progesterone may actually have decreased breast cancer. We're not promoting that, but people that don't have uteruses and are taking postmenopausal estrogens only, they actually may have decreased risk for breast cancer. So we really don't understand the hormone amount you need to stimulate versus inhibit a breast cancer. So I'm nervous about hormone therapy for treatment of side effects. Also, I wanted to comment on the soy-based preparations. There's this $3 million thing called the Soy Connection in Kernersville, actually, and about 10 years ago, they were touting all these soy bars and soy this, and it tastes like hay. We actually got some to try, but we were a little worried about soy because it is a phytoestrogen. It's a very weak estrogen-like drug. So they did a study in breast cancer survivors with soy-based preparations, and they actually don't help us with menopause symptoms. So we actually have data where they took a set amount. The problem with all these health food drugs is you don't, I might get it from Kathy and it has this amount. I may get it from Colby, it has this amount, so they're not like regulated. But they actually took black cohash and gave it to breast cancer survivors to see if it helped with menopausal symptoms. It did not work any better than placebo. So we actually have data.
Soy or black cohosh?
The black cohosh. We have data, but you know, some people say, well, my neighbor did black cohosh and it helped me and helped her, and you know, so I don't have a big fear of soy-based preparations, but they shouldn't help us in a randomized trial. So.
And the testosterone thing too, you know, several years ago, every talk show was talking about, oh,
right.
Testosterone is going to cure
Right.
your sex drive. I will tell you that for very few patients it makes a difference. And I have the biggest group of patients that I use it for is patients who've had surgical menopause, which is the same kind of thing as chemotherapy-induced menopause, where it's a very sudden, there's no gradual, it is ovaries are out and boom, you're in menopause. And for some of those patients, not even all of them, for some of those patients, if sex drive is a problem, I'll sometimes use estrotest, which is an estrogen plus testosterone. But it doesn't work for all of them either. So it's really, you know, although your neighbor might tell you, oh, testosterone's the answer, it's not.
It's the black bra on the table back there that's the answer. Some more questions. I'm going to ask a couple of things that just wanted to address with this, and I think that I want to draw attention to some things around the room. The women in this room look incredible. I'm sitting at a place where I can look out and see all of you. I see women who I've met through this job and through my own cancer journey. And from this standpoint, I can tell you, I know some of you have your breasts, some of you do not. Some of you have your hair, some of you do not. Some of you experience, probably a lot of you experience a lot of the same things but don't know it. I encourage you to continue to network with people like these people in the room. One of the things that really helped me when my hair fell out, because you don't feel real pretty when your hair falls out. At first, but you know what? I did shortly afterwards. The lady who has done my hair forever, I've been with her almost as long as my husband, she helped me figure out what to do with scarves, what to do with makeup, to help me when my eyebrows went. Talk with people like these in the room. In fact, talk with the people who are in the room here today, because you're the ones who have found ways to go on this journey and to raise your head high and to feel good. I mean, look at each other, and these are the people who are guiding you along the way. I tell a story, and Elaine on the first row here, I think is one of the most beautiful ladies I've ever seen, with or without hair, and I've seen you both ways. When I finally decided I had enough hair coming back in, I wasn't going to wear my wig anymore. I didn't really like wearing my wig. It didn't feel good. And I'd been, around the house I do it, but I didn't want to look odd going out, so I put the wig on. So I went to Food Line one morning early. Thought, I'm going to do it. I'm going to go out and I'm going to go early. And I found a scarf that looked particularly good, tied it on. You could tell back in here there wasn't much hair. I mean, it was obvious I'd been through chemotherapy. And this woman came up to me in the aisle of the grocery store, and she said, "You look like a ray of sunshine from heaven today." And I'm telling you, folks, we all need to be there for each other on these journeys, because from that point on, it was okay to go out without my wig on, because what we're saying is I am living with cancer. And I'm living with the treatment, and I'm here with all these other people, because it's almost like a little billboard. You probably know this. I'm picking on Elaine because we see her a lot. People now will come to you and say, "I understand, I'm doing this. How did you do this? How did, what to do with your hair, etc." You can feel pretty, you can feel desirable, you can feel real good about yourself. But it's a choice. It's a big choice. And it's hard to make the choice when you're real sad or you're real angry or you're real frightened. So the people in this room and people like this everywhere are your keys to feeling good about yourself, whether it's in the bedroom or in the classroom or in the office.